I'll tell the story of the child who was treated with multiple psychotropic medications over a 2-year period, had to go to a special school for behavioral issues. 4 or 5 different psychotropic medications, while the ADHD medicine stayed exactly the same. It was never increased or changed. But the child's mood and anxiety continued to spiral out of control. But it was because of untreated ADHD. So when we did the QB test on 36 milligrams of the medicine he was on and compared it to when he was not on medication, they were exactly the same. They looked like untreated ADHD. We double to the highest FDA-approved dose of that medication. The QB test stayed exactly the same. But we changed classes of stimulant from methylphenidate to amphetamine. It could have been the other way around, but in this particular case. And with the titration from 20 to 40 milligrams, the QB test normalized. And you know what happened at school?
He started doing better?
Much better. Citizen of the year, month or whatever within 3 months of that.
Oh, excellent.
We were able to wean and stop all the psychotropic medications.
Wow.
So if the providers that were caring, these were good people that were taking care of him, and they were treating the symptoms he was presenting with. So no one was doing anything wrong. It was just the wrong, it was just that we didn't have the ADHD under control and nobody noticed.
They just couldn't get to the source of
They didn't get to the source of the problem. So that is, I would say, one of my most compelling, or if not the most compelling story of how important objective testing can be.
So looking at changes in symptoms, right? Sometimes it is hard to quantify subjectively, right? You ask how your day is today, how are you feeling right now versus tomorrow. Not a whole lot of change in terms of your treatment time span, but end of the day, you're really tired. If you're filling out a survey, there's going to be some bias there, right? So we wrote a paper earlier in 2024 looking at our QB check data, using it as a medication management. And so is there a treatment effect? Can QB check pick up treatment effects? And so we looked at the assessment given at baseline and then post-treatment, and then looking at another QB check assessment. And you see a beautiful treatment effect in all 5 scores in the QB check, as well as total symptom score. And, that's very encouraging to see, because there is a quantifiable way, like you say, to really see how a patient is responding to the medication. And is that the right type of medication? Because also looking at the data, we actually graphed out each individual patient. We looked at the percentage change from baseline to follow-up, and with their baseline score. And it wasn't always perfectly linear. So most people got better, not everybody got better, and not everybody got better in the same to the same degree. So to your point, it is, like you were saying, you have to treat that individual patient. Are they on the right medication? And having objective data, I think, will really help clinicians like yourselves be able to see, okay, they're not responding at a half dose or at a double dose of this class of medication. However, if we switch him to a different class, look at his response on the QB scores. We're seeing a much better response. Let's follow this class of medication, see which dose of this class would optimize, this child, this, patient in their day-to-day life.
Right.
Yeah. I definitely agree. I think it helps, where preventing from underdosing, where, and then maybe even going up too high. And the other thing is that, sometimes by the time they get to like us, they have struggled so much. Yeah. And then with struggle becomes more struggle. And then maybe more behavior problems. And the parents are exhausted and the kid's exhausted. And then like you give them medication and they get better. And they're so rejoiced that things are better. Now he can just sit at the table and eat without me telling him 10 times. And they're like, I'm happy. And then but you're like, but are we really where we want to be yet? But they're so ecstatic that things are better, and they want to stop. And you're like, well, okay, let's just see where we are. And then you do the test, and you saw that it might have went from, the 90 whatever, and then you can say, look, there's still room for improvement, because sometimes they're so happy with anything because everything has failed so far.
Just stop short of the goal line.
And again, drawing the chronic disease model from primary care, my asthma is better. Well, does that mean you weren't in the ICU? You haven't had to go to the ER? Does it mean that you can? So I want the kid to be able to exercise at PE. I want the kid to be able to sleep through the night without coughing. There's some I want the symptoms in remission. I don't want them having, not just improved, but we want, and then you have to walk that careful line between optimal and then the little bit of blunting or losing their spark. Yeah. And I think clinicians like David and me are on the lookout for that all the time, because we don't want to change in personality. It's not necessary to have optimal ADHD symptom control. You shouldn't have to medicate your child in treating the ADHD. Right. You're treating a medical condition. You're not medicating the child. And so another way that objective testing, and I think this is so reassuring to parents when we have this conversation, is that if the child goes from, as David was saying, the 99th percentile, and the movement parameters and the attention parameters are way out, and then they come back on a dose of medicine, and all of a sudden the response time is like a robotic zombie did it, and the movement has gone from all over the little cross on the testing to pinpoint, then at least it cues me to say, whoa, is this too much? It doesn't say it's too much medication, but it definitely makes me put a pin in it and say, let's be double sure. Let's double check with the teacher. Let's check it on Saturday at 10 o'clock in the morning as the medicine's peaking, because sometimes 2 or 3 hours of blunting may be overlooked, and that's when we tend to do our repeat testing, right, is at the peak of medication effect.
And I think that's really a good point that you bring up, because clinicians like yourselves, it's really good that you are so proactive about getting to the right level without just shooting over and saying, well, it's fine, Right. And to be able to see that in a very measurable way, using objective data and saying, well, I think there's been an overcorrection potentially. Right. Mm-hmm. So let's reevaluate. Let's maybe recalibrate a little bit and see if we can find a little bit more of an optimal zone.
And sometimes kids and young people who have struggled with ADHD symptoms for so long are a little bit high on their dose, and they're feeling that. But I had a patient last week who didn't want me to decrease the medicine because of fear that the ADHD symptoms would come back and her performance would drop. This is a perfectionistic little girl, as you all often are. And she did not want to take a chance. And I said, listen, you don't have to be quiet at lunch to do well in math, right? You should be able to, when it's time to do math, do math. Yeah. We're not trying to use the medicine to regulate your behavior. We're using the medicine to connect the network so that you can self-regulate the behavior. And that's modern ADHD therapy, as opposed to when I was a young pediatrician, the goal was to calm mostly little boys down. And we didn't think of that as creating the zombie effect, but we must have known, right, because we recommended medication holidays, which are not a part of modern ADHD therapy in my view, because the symptom control needs to be very regular, and symptoms are affecting, whether we acknowledge it or not, the symptoms are affecting home life.
And also a little bit, it should be a little bit more predictable too. I would imagine as a patient taking ADHD medicine and then suddenly 2 days out of the week you're not, and you're feeling so dysregulated, and I feel like that'd be very confusing, for the patient.
And some people do poorly. I mean, I drink coffee every day, and if I don't drink coffee, I am irritable and I get a headache, and because I am, I rely on that bit of caffeine in the morning, and I say that can happen, sometime with stimulants, like and the stopping and starting could be pretty unproductive, and again, you give them education and you work with them. And as I say, this is not like a school problem. This is like a life problem, and it's going to impact the relationships, your guys' relationships, and the husband and wife relationship, the parent-child relationship, and the romantic relationships later on in life. And I say this, how they drive. Do they impulsively?
That's a huge one, driving.
Yeah. Do they impulsively buy things when they really can't afford? I mean, this is like we're helping you, yes, perform in the area that you're asked most likely to perform, but we want you to be able to regulate and think about things and put the brakes on, so you can then, not sometimes make mistakes that sometimes are hard to come back from. Yeah.
Stopping and starting medicine also can affect mood regulation. Often, especially in pediatrics, parents will feel like, well, we need to give him a break so he can eat more. And then they notice that when they stop the medicine, the appetite is really sort of supercharged. And I always point out that that's not necessarily a good thing. So the more the medicine is stopped and started, the more the appetite thermostat is reset. And so it tends to prolong the waning of the side effect of appetite suppression to stop and start the medication. Mm-hmm. So my corny little rhyme is take your medicine every day and the side effects should go away. If they don't go away over time, or they're not manageable over time, then you need to have somebody who helps you manage the side effect rather than avoiding the medication. Yeah.